Okay, that's grand.
I couldn't find my glasses. There was just a bit of a panic there at the last minute. And then I thought, Jesus, I should have checked what email was on, you start going through them all then. Anyway.
Yeah, no, that's fine, yeah. Okay, good afternoon, everybody. Okay, I can see you're all starting to come in here. So we're just very close to the hour. So maybe another 2 minutes and we'll get started. Okay, so by my clock here, I think we've just approached 12 o'clock Irish time anyway. You're all very welcome to this month's webinar. My name is Maeve Kearney. I am an assistant professor here in the discipline of radiation therapy in Trinity College in Dublin. And it is my pleasure to introduce this month's speaker, Dr. Aileen Flavin, a consultant radiation oncologist. So Aileen is a former graduate of University College in Cork, after which Aileen gained experience in radiation oncology working in Dublin, Cambridge and Toronto. Aileen then worked as a consultant radiation oncologist in Clatterbridge Cancer Centre in Liverpool for 9 years before returning in Ireland in 2005, working first for the Midwestern Radiation Oncology Centre in Limerick and subsequently Cork University Hospital and the Bon Secours Radiotherapy Cork. In addition, Aileen has worked with the International Atomic Energy Agency on several projects to improve access to and the quality of radiotherapy in low and middle income countries. Aileen's also a member of the UK Global Cancer Network and active in education projects in Nepal, and also a member of the ESTRO Radiation Oncology Safety and Quality Committee. But however, it is as her role as the NCCP National Clinical Lead for Radiation Oncology in 2020 to 2021 that is the reason that Aileen is here to deliver this particular webinar today. At the time, Aileen was the national clinical lead and led the response to the HSE cyber attack that severely disrupted radiation oncology services in May 2021. Some of you here today were possibly part of the response to this very catastrophic event on radiation oncology services. So over the next 40 minutes or so, Aileen is going to just share her experience in dealing with the cyber attack, trying to restore radiation oncology services, and I suppose to try and minimize the impact of the cyber attack. And there will also be an opportunity as well to ask questions. So I'll just hand you over there to Aileen. And Aileen, whenever you're ready.
Thanks very much, Maeve, and thanks very much for all of you attending. Can you hear me okay?
Yeah, we can hear you good.
Great. Yeah. So what I'm going to do during the talk is discuss cyber attacks on health systems in general, then introduce you to the organisation of the health service of cancer care and radiation oncology in Ireland, then get to the meat, which is the cyber attack and its impact on radiation oncology and how we dealt with it. And I suppose finally some reflections, some learning, and maybe some recommendations for you in your centres. Hopefully you haven't experienced a cyber attack. So just in terms of cyber attacks on health systems are common and they are increasing. There was a study published in 2022, which looked at a 5-year period from 2016 to 2022, and basically the number of cyber attacks on health systems doubled. In April of 2020, just after the COVID pandemic started, there was Interpol reported a big COVID effect. And I think that reflected us all adopting maybe more remote working. And that all happened very quickly, certainly in our case in Ireland. Suddenly people were isolating because they'd been in contact with COVID and they were working from home. So it was great, but I think it all happened very quickly, maybe without the right cybersecurity measures. The HIPAA in the States, they're responsible, I suppose, for monitoring patients' data and what happens to it. And from 2015 onwards, they started to record cyber attacks. And 2021, they announced that there had been a record number, 45.9 million. And however, in 2022, this was exceeded with 52 million, and 2023, it had exploded. And one of those attacks in 2023 affected 11 million patients, a single attack. So why are we seeing this increase in cyber attacks? I suppose the change to remote working during COVID was one of the things, but I suppose it's a crime that you rarely get caught. The IBM statistics are that 0.05% of cyber criminals get caught. So I suppose it's attractive. It's an attractive crime for criminals. What are the effects? I mean, it basically paralyzes a health system, as I'll demonstrate a bit later. Do cyber attacks affect patient outcome? There's very little data on this. There was a report in the Lancet Oncology last year which mentioned that the first death that was recorded due to a cyber attack was a lady in Germany who had a ruptured aortic aneurysm. And because of the cyber attack, the ambulance was diverted. Essential time was lost and she died. But I suppose the feeling is that there have been lots of deaths due to cyber attacks, because typically when they take out the whole system, they disrupt the ambulance service, and they also disrupt, say, intensive care equipment, etc., etc. So just the background to healthcare and cancer services in the Republic of Ireland. The Health Service Executive, known as the HSE, they're responsible for the delivery of healthcare. And the National Cancer Control Programme, known as the NCCP, is a directorate within the HSE, and it is responsible for implementing the National Cancer Strategy. We have a strategy every 10 years, but it also has a very important role in overseeing cancer services. With regard to the organisation of radiation oncology services in Ireland, Dublin, as you know, is the capital city. And in Dublin, there are 3 radiation oncology facilities. The oldest one is a standalone cancer hospital, and that's in St. Luke's Hospital on the south side. Then there are 2 other centres, St. James's Centre and Beaumont Centre, and they are located on acute general teaching hospital sites. So they're centres within a large teaching hospital. In Cork, again, it's Cork University Hospital, which is a large teaching hospital, and there's a radiation oncology department within it, and the same in Galway on the west. So these are the major public radiation centres in Ireland. These are the only ones. Now, we do have 8 private centres, which actually were very important for us during the cyber attack. So these are generally located in the cities, and they're smaller, maybe with 1 or 2 linacs. There's 2 of them in two of the smaller cities, Limerick and Waterford, and they treat private patients, but there's also an agreement with the HSE that they treat patients who are local, live in the local region. And I should mention that, I should mention first of all that the private centres were unaffected by the cyber attack. It was confined to the HSE hospitals. And just to mention that patients in the northwest of the country are treated in Derry, which is in the north of Ireland. There's an agreement there. So because the north of Ireland is within the UK, they weren't affected by the cyber attack, although there was some disruption to patient activities in the Republic of Ireland part, which, there was a small effect, but not great. So in terms of the cyber attack, what happened, it happened on a Friday, the 14th of May. I always think it should have been Friday the 13th, but it was Friday the 14th. And it was discovered early, I think it was about 1 a.m., that the HSE had been a victim of a ransomware cyber attack. So the first steps seemed to be to shut down all the systems, to assess the cyber attack and to prevent more encryption of data. But that first day, everything was effectively cancelled. Outpatients, clinics, all of diagnostic imaging, all of radiotherapy, elective surgery, everything was cancelled. There were urgent blood tests done, some radiology and some urgent surgery. And I suppose a very important thing was that all communication within the HSE was lost. So you couldn't email anybody, you couldn't phone any department. We had no communication. So going into work was like just going into almost like a war zone. There was nothing. In terms of radiation oncology, radiotherapy stopped in all of the 5 public radiotherapy facilities. And in total, there were 513 patients on treatment at that point that had their treatment interrupted. We had no access to the oncology information systems or electronic patient records. We had no access to shared drives with any procedures or protocols. On the 20th of May, the cyber attackers provided a decryption key, which was helpful. Apparently no ransom was paid, but the story was, and you never know really what the story was, but that that some of them were good guys and felt that they saw on the media the effect of the cyber attack. Anyway, but basically there was a decryption key, which was helpful. But it took from the 14th of May until the 30th of May for radiotherapy to resume in all of the public centres. That was just over 2 weeks. So the NCCP role in the cyber attack, as I mentioned at the time, I was the lead radiation oncologist. We had formed an NCCP response group during the COVID-19 pandemic. So we literally reinvented ourselves on Friday the 14th of May to form another crisis group, which was the cyber attack group. And that was multidisciplinary with myself, some of the lead radiation oncologists from the different centres. We had input from RTT, medical physics, nursing, and we also had an IT expert from the HSE. And I suppose day one, we were completely shell-shocked, but our priority was that if patients required emergency radiotherapy, that they would be treated. It was a Friday, and as we all know, the emergencies tend to happen on a Friday. So arrangements were made locally with private hospitals, and that happened very, very, very easily. We had lost communication, and I suppose we didn't have, one of the centres did, but most of the centres didn't have any information on who was on treatment, names, addresses, phone numbers. So we had to develop a communication system using the media and the HSE websites. And basically we told patients to contact us, and we set up a helpline. We had no telephones. A special helpline was set up so that we could communicate with them. There were a few patients due to have cervical cancer brachytherapy, which is time dependent. So they were transferred. The Mater Private Hospital in Dublin has brachy, so they took on those cases. And I suppose this multidisciplinary team met every day until we had patients back on treatment in all of the centres. And I mean, sometimes people were in their car, on their phone. It was, you know, the circumstances were really suboptimal, but we did meet. Also, I've mentioned the private sector, and we have a big private sector in Ireland. I suppose what was helpful to us was that there already was an agreement in place called Safety Net 2, which allowed for public patients to be treated in a private hospital. Initially, during COVID, there was a real concern that the public hospitals would be overrun and there wouldn't be ITU beds, etc., etc. So this agreement was in place, but it was modified, and the difference was during the cyber attack, it allowed patients to be transferred, but also staff to transfer to private hospitals to work. And this was a huge help to us that it had already been set up. In terms of the multidisciplinary team, I suppose our priority really was to get the service going again, get patients back on treatment. So we worked together well as a team, and I suppose we developed a consistent approach to our problems. So a consistent approach to prioritization of patients for the resumption of radiotherapy, a consistent approach to gap compensation. We also, to protect staff and to protect from decisions that were made during the cyber attack, we created a risk assessment form, and this was particularly relevant if you were sending patients to a private centre for treatment where you were replanning patients with a lack of information. I suppose one of our big roles was to ensure that radiotherapy was prioritised by the HSE, that they realised how critical it was to us. Surgery started to continue, other things continued, but we were totally IT dependent. So the message got through, although it took a few days, that radiology and radiotherapy were completely paralysed and we needed to be prioritised. And there was lots of media coverage of cancer patients whose radiotherapy had been stopped as well, which was helpful. So this is just a document showing the approach we took to prioritisation of patients to resume treatment. And basically, we prioritised our category 1 patients, so our radical head and neck or cervix. We prioritised paediatric cases on treatment. And we prioritised patients who are already on treatment. So if you were already on treatment, we didn't want you to have a gap. So our priorities changed from normal. In terms of compensation for gaps in treatment, we had produced an NCCP document for dealing with gaps during COVID. So I suppose we adopted this. The physics team from Galway created an Excel spreadsheet which was shared with the rest of us. When patients got back on treatment, patients were generally treated 6 times a week. And I suppose this meant that there usually wasn't a huge need for compensation. I suppose a kind of a rule of thumb would have been that maybe for quite a few patients, we added an extra 2 grey when we looked at the Excel spreadsheets, etc. Compensation was more difficult. It was easier for people at the beginning of the treatment, but at the end of treatment, it's more difficult to add dose. And particularly when you were looking at a plan that maybe was close to or exceeding the dose volume constraints for the normal tissues. So difficult decisions had to be made. I suppose, I think it's important to acknowledge that, you know, we had our Excel spreadsheets and we have our radiobiology, but really the formula that are used were never really intended for the gaps that we encountered, the 2-week gaps that we encountered. They were more for a few days. And I think we really don't know what the long-term effect was or will be on our patients. And certainly I would say that there was a psychological impact as well for everybody, really. This is just an example of the risk assessment form that we had for transferring patients to a private centre during the cyber attack. And I suppose basically what you were documenting, say I had 4 cervix patients on treatment, so you were documenting the risk of sending them to the private centre, maybe with not all of the information and replanning them, versus the risk of leaving a prolonged gap in their treatment. And it was very difficult. I mean, it you know, sometimes whatever you do will be the wrong thing. And I'm sure, I'm sure some people suffered because of it. So what happened at each centre was a little bit different because of different information systems and treatment planning systems. But in general, daily crisis meetings were held, incident rooms were set up. Brachytherapy and superficial skin units, we didn't know at the beginning that they weren't affected, but they weren't affected by the cyber attack. So that was good. In terms of there was a huge amount of redeployment of staff. I mean, staff weren't treating patients. So in my department, the radiation therapists were communicating with patients. They were doing administrative tasks. I suppose retrieving information. We'd lost all our information, so we were trying to get it from every source possible. Even the letter we'd sent to the family doctor to begin with, we were asking, can we get those letters back? Because the general practice or family practice was not affected by the cyber attack. So we're trying to get information from everywhere. We went back to paper records. There was a huge amount of work transferring patients to the private hospitals, getting CD-ROMs burnt of their images so that they could be replanned. And we established Silo. It's like WhatsApp, but it's GDPR compliant communication. So we were sharing images and everything really. I think it's important to say that all routine activity was cancelled. So all outpatients for new and follow-up patients was cancelled. And I think in a crisis situation where you're just trying to get the people that you have back on treatment, something has to go. And we decided that would have to go. And that was a national decision. Just to mention, I suppose, that the radiation therapist, again, they triage the referrals, just making sure that there wasn't an emergency like a spinal cord compression in the middle of all of these referrals that were flying in. So I'm going to just go through quickly what happened in the different centres. So in Dublin, there's a total of 14 LINACs. And as I've mentioned, there's 3 centres. St. Luke's Hospital is a mixture of Varian and Electa with Mosaic and ARIA as their OIS, and they've OMP and Monaco treatment planning system. So it's a bit of a mixed bag. St. James's Centre and Beaumont Centre, both have 4 LINACs each, and it's Varian, Eclipse, ARIA department. So in that network, in the Dublin network, 304 patients had their treatment interrupted. Now, one of the things was that they had ARIA servers located in St. James's Centre. They had their own IT. So on the weekend of 14th of May, they isolated ARIA onto a clean computer, and they were able to retrieve all the patient details. They were able to look at who was category 1. They were able to identify the children, and they were able to prioritise their patients for a resumption of treatment. By the 18th, they retrieved all the treatment plans. By the 18th of May, so that was the Tuesday, the attack was the Friday, they had a LINAC which could treat patients at St. James's Centre. So all of their priority, the category 1 patients were back on treatment by the 19th, as were the children, and the remaining patients resumed treatment on the 24th of May. So that network was the fastest to get back treating patients. Now, they are unique in that they host their own data, and they have dedicated IT staff and engineering staff. And I suppose the other thing that helped them was that they had experience of an ARIA failure after an upgrade in 2019. So that impacted them. They lost, they weren't able to treat patients for a few days. I think they learned a lot from that in terms of what to do when it all fails. So I think that they were better prepared than any other department. But that said, it was the 14th of June. So it's kind of a month after the cyber attack before all of the LINACs were operational in St. Luke's network, and they were very dependent on the private centre. They sent all of their routine sort of breast and prostate work to the private sector, as well as their SABRE and their stereotactic work. In Galway, Galway at the time had 3 Siemens LINACs with Mosaic and Monaco, and they had 73 patients who had their treatment interrupted. Now, one good thing they had, and I think it really is to be recommended, they had a list of patients on treatment held on a separate computer, and they retained some paper records. Their big problem was that their private hospital had very little capacity. So you had 73 who had stopped their treatment, and they had only the capacity to treat 20. They were, I suppose they still had some category, by the end of the first week, they had some category 1 patients who still hadn't received treatment. And the plan was for the patients to transfer to St. Luke's in Dublin for replanning, etc., on the Monday, the 24th of May. But in fact, things started to happen. And anyway, in the end, they recommenced their treatment on the 26th of May. Their gap duration, the median gap for the category 1 patients was 6 days and 8 days for the rest of the patients. So Galway got up and running. I mean, these gaps are terrible, but I mean, they under the circumstances, they did very, very well. I suppose there's a saying, it never rains, but it pours. On the 1st of June, which, the 3rd of June, I think it was after we have a bank holiday in June, they came in to find that one of the Linac rooms was flooded. So they were down to 2 Linacs for a few days again, but I think that was, that wasn't so bad really. So in Cork, where I was based, 5 Electa Linacs and Mosaic and Monaco as the OIS and TPS. So 136 patients in Cork had their treatment interrupted. What happened on the 19th of May, which was a Wednesday, I can remember every day in detail. On a Wednesday, there was an agreement that patients under the Safety Net 2 agreement was that patients could be transferred to the Bonds UPMC private centre, and they would allow CUH to use a Linac, and they felt that there was the capacity to treat 70 patients. Now, the staff, they didn't have the staffing, so the staff were redeployed from CUH to the Bonds to work, and you can imagine the induction and people working with unfamiliar equipment, etc. But radiotherapy in CUH wasn't re-established until the 30th of May, and we were the last to finally get people back on treatment. Our median gap duration for category 1 patients was 6 days, and I think this was because we got people treated in the Bonds. The category 1 patients were all transferred down. We have a long gap for a patient of 17 days, but I think she was an outlier who had brachytherapy, I think became unwell. And for the rest of the patients, it was a 10-day gap. So I suppose the Bon Secours it's a Varian department. So Varian provided lots of extra licenses, so as all the staff from CUH could do their work. Varian also own another company called CTSI Oncology Solutions. So they offered medical physics and dosimetry services. So it meant that there were dosimetrists in multiple time zones doing round-the-clock planning, and this was of huge help to us. Just from my own point of view, I suppose, because I was doing the lead National Cancer Control Plan job, I wasn't as clinically busy. I had about 20 patients on treatment, but I suppose I had quite a few cervix patients, as I mentioned. It was really like saving patients one by one. You were just kind of trying to prioritize them. And I tended to try and phone them every second day just to say, I'm not forgetting about you. We were desperately trying to get information from everywhere and anywhere. That was a big problem, transferring people down. You knew that replanning them without at least a basic amount of information was dangerous. I can't describe how tired we got, particularly the first weekend. So we had the agreement, I think, on the 19th, but that first weekend we just worked flat through the weekend, and huge amounts of overtime were done by people. I think what was a really good idea, and again, I would really suggest this in a cyber attack situation, we normally peer review all treatment plans. We were in a kind of an unfamiliar surroundings, but we did say we would do a peer review. And I think this is really important when you're tired, when everyone's tired, that you actually look more closely at your work. But the Bonds were treating patients 7 days a week. for 7 weeks, and they started at 8 and they finished at 10, and patients were being treated, you know, late into the evening. So there was no normal life for any staff. And I have to acknowledge the flexibility of all my colleagues. Everybody was great. And I suppose the patients, like I felt the patients were great, like, you know, in the middle of your treatment, like such a disaster to happen. And people, there was just no complaining, and there was such gratitude that people really knew that you were trying to do your best for them. In terms of just these two tweets, I suppose one is from a medical physics colleague and one is from a radiation therapist, but I think that they kind of describe the scenario of trying to get all these patients back on treatment and planning over 70 patients in 70, 80 patients in a few days. It just required, I suppose what it was it was kind of like a war mentality of just everybody helping out, and everybody. I think what really struck me was how much everybody was distressed by patients not being able to treat patients. I remember one RTT said to me, I remember going back to CUH where she wasn't treating in the bonds, and she just said, I can't wait to treat patients again. So just the distress from the whole thing. There was an awful lot of bad eating and crazy stuff that went on. I'd say we all gained a bit of weight. This picture just, I suppose it's just kind of reminds me of how desperate I was to get information. The image on the left is one of my cervix patients, and she had involved pelvic nodes, and my original plan was giving her a simultaneous integrated boost. But when I went to replan her treatment I did have the CD-ROM of the PET scan, but, you know, it was on a small laptop. As you know, most computers now don't have CD-ROM drives. So I just wasn't confident. Maybe I was tired, but I just wasn't confident that I could really be sure about the nodes. So I changed it to a sequential boost. But I suppose what these images, when we got access to the server and everyone was competing for trying to look at what, you know, images, everyone was competing. But when we got access to the server, I just took loads of pictures, and that allowed me to plan a sequential boost for her. The image on the right then was a lady with a maxillary antrum, diffuse large B-cell lymphoma. She'd had chemo, but I wanted her pre-treatment PET. So I transferred her to the bonds and she'd had her CT plan, replanned, or CT for replanning done, but just because of the cyber attack, they couldn't retrieve her PET CT scan. So I just couldn't get my hands on that, and I was waiting days. But access to this allowed me to see what I had planned initially, so I could just recreate the volume. But I think it just gives you an idea of what it was like. So the initial 2 weeks were terrible, and I think the second week in particular, the first week you had this idea, it'll be sorted. Somebody will come along and they'll sort it. But the second week you kind of felt this is never going to end. It took months to get back to normal, and people, you know, systems were crashing and you were losing your work. One of my colleagues worked for hours catching up with loads of contouring on the backlog of patients. And she said she stayed until after midnight in the hospital, and she lost about 5 hours work. So there was stuff like that happening. We still had no access to imaging for ages, I would say for months. And email, you couldn't email colleagues, you were using their personal emails. And then there was a big backlog of patients because, as I mentioned, we stopped all routine activity during the cyber attack. So there was a big backlog of patients and they had to be dealt with. So we were using the private system right up until, you know, the end of the year. So for over 6 months. So I suppose what's the learning it was a nightmare scenario. So what's the learning for the health system? The HSE recruited PricewaterhouseCoopers to do a review on the cyber attack. And I suppose what came through was that it was a very unsophisticated cyber attack. And it was basically somebody opened a phishing email. The email was delivered on the 16th of March, 17th is St. Patrick's Day, so they opened it on the 18th of May. And apparently there was a lot of concerning activity. People were noticing things with their computers between the 16th of March and when the ransomware was detonated, but and things were reported, but I suppose there was only 15 staff in cybersecurity in the whole HSE, and there was a lack of governance. There was really nobody to report up to, reading the report. They said the IT systems were frail, and I suppose a lot of hospitals, the Windows 2007 were, real old systems. So I suppose they highlighted the need for investment in IT, but also, I suppose, as well as IT, the need for investment with cybersecurity. And I think really importantly, governance structure. You need somebody to be in charge. So you needed the cybersecurity, you needed somebody that people in cybersecurity can report up to. They said it could have been worse, which is kind of hard to understand but that the decryption key, which was provided by the cyber attackers for whatever reason, that was helpful, and it could have been worse. So in terms of what they estimated that the cost, I have it written down somewhere, but the cost of implementing all of these changes was something like 100 million, just a huge amount of money. No, it's more than 100 million. It's several hundred million. But anyway, what has happened, I suppose the HSE has now moved to a single domain. Before there were 8 domains. So the IT system was fragmented regionally, and that makes it more difficult to monitor. So it's moved to a single domain. Cyber surveillance was ramped up. So firearm monitoring. So basically monitoring everything that's coming in and out of the system. Education has really been upped, and there's mandatory education that all staff have to do, and they get sent test emails. And if you open, say, the Excel spreadsheet like the person did on the 18th of March, you get a request to do more training. There's much more emphasis on what they call cyber hygiene, changing your password, authentication, and that type of thing. And there has been a lot of recruitment of cybersecurity staff, and I suppose in particular the governance part of it. So there was a recommendation that you have a chief technology transformation officer, and there's still a lot of work to be done to make us more digital, which we do want to be, and also a chief information security officer who's responsible for cybersecurity. So I suppose what's the learning for radiotherapy? Cyber attacks are frequent, and they're getting more frequent. Just before our cyber attack in April, there was a big one in the US, which was on the Elekta record and verify system, and more than 200,000 patients were affected by it, and it caused a huge amount of disruption. But I was unaware of that. We all live in our own worlds, and we're unaware of what's going on in other places. And just after our cyber attack, there was one in New Zealand, a smaller attack, but nevertheless, it really impacted on radiation oncology. So in the last few years, there's been a lot of publications on cyber attacks, what they're like, and how to deal with them, including our own one, and one from the St. Luke's group in Dublin. But basically, what they all have in common is that they cause huge disruption to radiotherapy, can be from 2 days to over 2 weeks, that they're extremely tiring for staff, and it takes a long time for your department to recover. Obviously, the worst is over after a few weeks, but you're still recovering for months. And they strongly recommend that you do dry runs, that you plan for disaster. So you have a plan for all disasters, not just cyber attacks, but it's a similar plan, really. This was a disaster. And having one's own servers in radiotherapy departments, again, the St. Luke's network had their own server, and they got up and running very, very quickly. And having backup data as well. In terms of preparing for disasters in your department, I'd really recommend this article. It was published in Practical Radiation Oncology in 2019, and it was lessons learned from Hurricane Maria in Puerto Rico. And I suppose it really is good for any disaster, but it was the most downloaded article in Practical Radiation Oncology in 2020. And I think this probably reflects the COVID pandemic, where we were all wondering, would we be able to keep the service going? And it's a very honest look. I mean, they say it's a list of what we wish we had done beforehand and what we needed most afterwards. And they emphasize the preparations. You need to prepare for it, and how important communication is. And that was very difficult for them because there was no electricity, there was no fuel. And I suppose they emphasize really what you must really focus on is operate, get back treating patients. And obviously they have quite a bit on compensation, which is very good. Cyber resilience. So I suppose cyber resilience is the ability, this is from a Canadian article, the ability of an organization to respond to, contain and manage a cyber attack with the objective of minimizing operational impacts. So I suppose cyber attacks are a sort of a fact of life, but how can you minimize the impact it has on your department? And there's not very much literature on this. There was a paper published from a group in Baltimore, which they haven't had a cyber attack, but they've worked on having a kind of a parallel oncology information system for every patient on a secure server, which seems like a great idea. Now, other people are looking at things. I've been in touch with the Belgian Hospital Physicists Association, and they're doing quite a bit on, maintaining the service. How can you continue the service in your own department, ideally? But they're trying to create a network so that that the patient doesn't have to be re-CT'd or replanned. So they're doing some provisional work on that, but they say that they haven't cracked it yet. Personally, I feel that the vendors have a role to play. I think they've stayed quite quiet about cyber attacks, but I do think that they should be helping us in terms of keeping the show on the road. So what is the radiotherapy community doing? Well, I suppose internationally, the AAPM in the US and European EFOMP are working on creating a cyber attack document, and ESTRO, the ROS committee, are also hoping to publish an article, but that's going to be around, I'd say, 2025. So I suppose the question is, what can you do in your department? And this is the NIST, they're the National Institute of Standards and Technology, and they have produced a framework just very recently for, I suppose, reducing your cybersecurity risks, which is really very useful. It's a very long document, but there are some basic points that I think that there's a framework that any department could work with. And just to it's identify, protect, there's 5 things: identify, protect, detect, respond, and recover. And so I think anyone could use this. So identify is assess your risks, where in what part of your system do you have risks of cyber attack? And then once you've identified them, how can you reduce those risks? Detection, as I mentioned, in our system, there were lots of things happening, and these cyber attackers had access to the system for 2 months. They were able to root around. Whereas if we had had better governance, etc., but also detection systems to pick up any unusual activity, and this could be, something like more incoming traffic than normal, and that's counted. That can be counted. So early detection, responding, then how you're going to respond, how you're going to reduce the effects, how you're going to minimize the gaps in treatment, because I suppose that's our main goal in radiation oncology. And then recovery is full restoration of the operation. And as I said, there is a recovery period of months. Can you make that a little bit quicker? So it's very much for you to see where your gaps are and to self-assess, or you can also use it to assess other departments. This could be used as a tool if somebody said, can you assess my department? You could use it. So to conclude, I can't overstate the impact of a cyber attack. You know, it's just a nightmare, and I'd really never want to go through one again. Prevention is really important. So investment in cybersecurity and IT is critical. But we have to, you're only as strong as your weakest link. So you have to accept that they're a fact of life. As I've said, they're very frequent now, and they're getting more frequent. So you have to plan and don't live in the moment. I suppose we're always been told, and I try and do it myself, live in the moment. Don't worry about tomorrow. You know, we worry too much. Cyber attacks don't live in the moment. I think you need to think this could happen, and I need to be able to deal with it in my department. You need to ask yourself, how resilient are you if attacked? Can you continue your service? And I really recommend the NIST framework is a nice one, but there are other ones as well. But use some sort of framework. Even if you have a simple 2 or 3 pages, the document is very complex, but just a few pages, it'll be very useful if you have a cyber attack. Departments need to risk assess each step of their process in terms of cyber security. And again, when introducing new technology, you need to think about it. I would emphasize the importance of keeping basic patient information. We didn't have that, and you know, it took up a bit of time. And I think, you know, just for patients, we could have communicated with them. And the number of fractions that people have had, again, that was, you know, we were trying to count from hospital A to hospital B, and there was 1 or 2 mistakes. Now they were corrected, but that can be quite tricky. I think something that we need to think about is having a good relationship with adjacent centres and maybe twinning. That's what they're doing in Belgium. There are 2 centres looking at, you know, can we use your images, etc., etc. So I think having a good relationship with adjacent centres is really important. Sometimes we're rivals, but I think we need to overcome that. Being able to store your own data with dedicated secure servers rather than relying on hospital systems is important, and certainly for St. Luke's and in Vermont as well, that helped them get up and running more quickly. IT support, you know, I think IT support is really important in a radiotherapy department. Like, we are the most IT dependent, as well as radiology, I suppose. But in CUH, just to give you an example, when our new centre opened in 2020, IT was outsourced. We had a guy who did all the IT. You'd just be, you know, the poor guy, but you'd email about him about everything, and everything was sorted. We didn't have, the IT was outsourced, but because of the cyber attack, they weren't able to help us remotely. So it was a very bad idea. And we didn't have the relationships with the hospital IT that if we'd had our own guy, he had that relationship. So he had retired, but just, you know, I think that was something that seemed like a good idea, but it was a really bad idea. I think the other thing is to make sure nationally and locally that IT are aware of how dependent the delivery of radiotherapy is on IT. And that in Ireland, the Chief Information Officer at one point made a statement. Somebody told me that he hadn't realised how important IT was to radiology and radiotherapy. And my first thought was, well, that's really bad of him. You know, he should have known. But actually, when I kind of reflected on that, I thought, actually, it's us. We need to tell people. People don't know about radiotherapy in general, you know, hospitals, they don't. So I just think that people need to be sure, both nationally and locally, that IT are aware of the importance of IT to radiotherapy. I think just finally, what helped us was the COVID resilience, and from the National Cancer Control Plan, we were used to working in the same team in terms of disaster planning. So it's really good to get a group together, you know, to support each other, to share ideas, and we had a consistent approach, although that worked well, although, you know, I suppose we didn't get up and running as soon as we'd hoped. So I think that's it, if people have any questions for me.
That's great, Aileen. Thank you very much. And I think I'd probably join the rest of the attendees in, you know, giving you absolute credit there, how hard you all worked together at such a distressing time, how resourceful you are. And I think it is very important as well to really, constantly share the impact of this, because, it can be very simplistic. Cyber attack on the 14th, decryption key the 20th, when, as you've shared there, the impact of it, like, we're probably still determining aspects of it. So, thank you very much for sharing all of that there. So in terms of questions, there is one from one of the attendees, and I might just add to that as well. So the attendees just wondering, how did the attackers gain access, and how can they be prevented? And you mentioned there as well that between March and May, there was concerning events. Like a staff recalled some concerning events. Would you mind maybe commenting on that, and how we could all probably be a little bit more vigilant?
Yeah, I mean, one of my colleagues, I mean, and I suppose, basically got an email to say that he had just changed his password 2 days earlier, and he got an email to say that he needed to change his password, and he was very surprised by it, and he contacted an IT person who said, well, it was purportedly from the head of IT, which he thought was strange as well, asking him to change his password, because normally you get a fairly automatic email. But so he contacted him, and he said, I didn't send you an email. So I suppose it was events like that that's the only example I know of. But there does, according to the PricewaterhouseCooper report, there did seem to be concerning things that were discussed among IT people, that there was stuff happening, but I suppose they weren't aware enough of it. And I think it sounded like there was 15 in cybersecurity, probably completely overstretched, and they didn't have anybody in charge. I think that was the whole governance, I think, was poor. That's all I can kind of say, really. But I think how they gained access was the phishing email, like we get all the time. I know, I mean, even after the attack, I was stupid enough to give my bank details. Anyway, you would imagine you'd be, but these things, they're very clever, and they're done to, and I suppose sometimes, you're just at your computer, maybe you're doing something else and opening emails. But I think that's something that is very basic, and you certainly need to be very aware of it. But at the same time, when you're dealing with huge organizations, all it takes is for one person to. But then I suppose once that happens, I think the 2 months, definitely the stuff that was happening in the meantime, that there should have been somebody to report that to. So I suppose if you're seeing anything strange, you should be reporting it up along the line.
Yeah, but I think some of those phishing emails, though, they can be very, very credible. Sometimes it's very, very difficult to identify
Yeah, yeah,
what might be suspicious or not.
yeah, yeah.
I'll go to Michelle. I just have one more question from an attendee. You mentioned briefly, Aileen, about Silo. Can you just tell us a little bit more about that?
Oh
Is it
yeah,
like a help?
Silo is really good, and it's an app like WhatsApp. So basically, any of your contacts that are on it, it's just they'll come up on WhatsApp, but you can transfer like photographs, say skin lesions on patients. So it's not just for cyber attack. It's very good. So you can send photos. We were able to send, pathology reports, and what happens is it's GDPR compliant. And after a month, all the images go. So they stay on the system for a month, and then they go. So it's something that I feel that we really, really should be using that more in healthcare in Ireland.
Okay. All right. Sounds like a good resource. Michelle?
Hi, Aileen. Thanks. That was great. Um, I was just wondering, and I know there's international participants here as well, and we don't have a national electronic health record in this country. If we had had that, would things have been easier afterwards?
I mean, I always thought that things would have been worse, but it's just that I suppose medical oncology were able to keep going because they had paper chemotherapy prescriptions, I suppose surgery were able to keep going because they had the notes. So I think that the more digital everything is, the more you're vulnerable to a cyber attack. So I think it probably would have been worse, would be kind of my interpretation. And the fact that in radiotherapy we are so digital, that's why we were affected so badly. I suppose the thing is, because somebody once asked me when I gave the talk, is should we go back to paper records? And I think, you know, the answer to that is no. And we should definitely be more digital in terms of safety, you know, general patient safety, particularly things like pharmacy, prescribing errors, all of that, that if we were more digital and if we could all speak to each other. But that, I think, exposes us more to being attacked, and therefore we have to be more, you know, I suppose, you know, we have to be aware of that it comes with very good aspects and it comes with downsides, and the cyber attack is your downside.
Yeah, I suppose I was thinking more along the lines of, would GPs have had those records? Do you know what I mean? They might have had something on the patient, you know, with an electronic, a national electronic.
Oh, yeah, yeah. I don't know. Would they have been attacked as well then? I don't know.
Yeah, no, I'm just wondering. I'm trying to
Yeah,
think.
yeah.
So, some kind of I suppose things in, because there's a big, obviously, as you know, national discussion about having you know, I suppose we're one of few countries in
Yeah.
Western Europe that
Yeah.
don't have one, you
Yeah,
know. So
yeah, yeah.
thanks very much.
Yeah, and I think, yeah, Aileen, like it is clear, like we're just becoming increasingly more digital, and you know that's the way we want to go. It is obviously more efficient. And you mentioned there, like as I suppose as part of the response, there was a recruitment of additional cybersecurity staff. Was this at a national level, or
Yeah.
was it within
I think
individual?
it was national and regional, but the investment, I wrote it down here just in case anyone asked me, but I've lost my piece of paper. The investment, yeah, just in terms of millions, sorry, I'm not good on money, but the investment, yeah, 700 million euro to get us up to scratch. And some of that has been, I mean, they've done an awful lot. They've done a lot of what they can do. I think that they have had staffing issues, though. There's an international shortage of cyber security personnel. It's certainly a good thing to get into for anybody coming up, I think. But and I think that they have found, particularly you know, the chief, you know, the head of departments of your cybersecurity, they found filling those roles quite tricky, as far as I know.
Right. Okay, so we're probably lacking that within the multidisciplinary team at the moment, a dedicated cybersecurity person. And is that something that we probably, for workforce planning for the future, should definitely be factoring in?
Yeah, I mean, I think that cyber, you know, somebody in a radiotherapy department, again, as I said, you know, the Cork thing where we lost our IT person, I think you definitely need IT personnel, and you need somebody who's responsible for cyber security so as that people can take a problem up to that person. But I think cybersecurity is more than that. I think it is all of us. We all have to, it's a bit like wearing your seatbelt. We can't leave it to somebody else. We have to, you know, we have to be good with being careful with the emails that we open. And I suppose we also have to be good at reporting any funny stuff. And you know, life is busy, it's not perfect. And sometimes you kind of feel, you know, I can imagine that you've got so much to do, and then you have to kind of report this, that you got a funny email. But I think that it is everybody's responsibility, is what I would say. But yeah, it's everybody's responsibility, and we must all be aware. And I think, you know, we can't, nobody, if you do have a cyber attack, you're on your own, and you'll need to get out of it. So I think that you certainly need to have some sort of a basic plan for it in your department. And as I said, it could be a very brief thing, but it might even be, you know, are you keeping patient records on a secure you know, somewhere secure? Have you got your procedures and protocols somewhere else? But even some basic things will help you in a cyber attack. But I think, like, you know, at the moment, the relationship with another department, I think, is very important, you know.
Yeah. No, definitely that there is an element of individual responsibility. And I just have one more question, because I know we're nearly out of time. But you talked about the increasing the ARIA, or sorry, the Eclipse licenses, and there was treatment planning happening all over the world. How did that work in, I suppose, keeping the treatment planning techniques consistent? Because obviously, you know, if you were to give, say, a radiation therapist or dosimetrist or whoever plans, you know, a PTV, they might all decide to plan it in different ways. How did you
Yeah.
keep it?
I mean, all I can say is that a lot of the plans, you know, that I would have dealt with would have been VMAP plans, and from my experience, they seem to be the least complicated in terms of they were being churned out very, very quickly, and the plans actually looked very good. I remember thinking that. But yeah, I know what you're saying, and I do think that, you know, I'm not a radiation therapist, but I think that there is a huge difference between one LINAC and another, and having to go. I think that what they tried to do in our case was send the people who had some varying experience to the Bonds UPMC. But yeah, I don't know if I've answered your question. Sorry, now I'm getting a bit distracted.
No, that's, yeah, no, that sounds like, yep, just that radiation therapists, they weren't seeing something very, very unusual and then unsure of how to verify it then, you know, when it came to IGRT. But it does sound like it was quite consistent.
Yeah.
But,
And I just think that we worked very well as a team, even though there were, you know, again, people that you were dealing with, radiation therapists that you hardly knew, but you know, that kind of crisis mentality, like, kind of set in, and you know, I was happy enough with that side of things. I think the plans that were good. I suppose the contouring was, you know, you would be a bit concerned about that, but the RTTs did a good bit of the organs at risk for us as well, which was very helpful, you know.
that's, yeah, certainly, yeah, radiation therapists very much involved in delineation. So we've just come to 1 o'clock there Irish time, so we have come to the end of this webinar, and thank you very much, Dr. Aileen Flavin, for sharing this. I know you've you've shared it nationally and internationally, but it is always good just to remind us of the important messages. So thank you all for attending today, all our attendees. Just to remind you that this recording will be available on the Discipline of Radiation Therapy website shortly, so you can use it for your own information. And I hope you have a lovely day, and please do join us at our next webinar. Okay, have a lovely day, everyone. Thank you very much.
Thanks very much.
Thank you very much.